Okay, this is what I was talking about. So this line isn't accurate. Normally you cut right along here, dislocate the patella. In thin patients, some people can cut along here and then go along here and then move the whole muscle. So you're not cutting the tendon. So if they said, I'm not going to cut the tendon, I'm going to tear the muscle, that wouldn't sound as good. At the end of the day, it's surgeon preference. The studies actually show there's a higher incidence of complication if you do this. But again, you go to a surgeon who does what he does, who's good at what he's doing, and it's not something that you would ever know about unless somebody used it as a marketing issue. Generally, we get our patients, when this initially came out, people used to say, well, we get people home a day early. Well, we send patients home the same day, as do a lot of people, so that's out the window. Basically, you have to dislocate the kneecap. A topic which is not on the slides, but I will raise since I have it is, do you need to resurface the kneecap? The answer always was yes, and I do about 95% of the time. Some people now are saying you don't necessarily need to do that. And I actually did a patient recently where I didn't. If the kneecap is perfectly pristine, again, some people are more inclined to leave that alone than others. The jury's out as to what the role is in terms of whether you need to take the kneecap out or not. The standard technique has always been to resurface the kneecap. Next slide, please. So who's a candidate for a knee replacement? Okay, next slide. Okay, depends on how old you are, your health, how much you weigh, what you're expecting, what your activity level is. Generally, the older, the better. The key is you want to do this while you're healthy enough to do it. You don't want to do it until you have to do it. You don't want to wait until you're desperately in need of it, and then you have a number of medical conditions. So you kind of have to walk that tightrope. Weight has become a big issue in the last couple of years. Literally, there is a cutoff. I have an app on my phone. It's a BMI app where I ask people how much they weigh and how tall they are, and it comes up with the BMI. And if your BMI is over 40, you're not qualified for the surgery. There's a little wiggle room there, but the studies show there's a much higher incidence of complications. If your BMI is over 40, it's astronomically higher if your BMI is over 50. Problems with wound healing and things like that. This being well, America, but everywhere, 70% of the people in this country are overweight or obese. And it's obviously good to lose weight for a lot of other reasons, but I'm frequently in the position of telling people, you're going to need to lose weight before you can have the surgery. It's not that we don't like people that are heavy. It's just that the studies show that people are heavier have a higher complication rate. And again, you don't need to be a size 2 to qualify for the surgery. To put it in perspective, probably should have done this earlier, but if you're 6 feet tall and you weigh 285 pounds, you still qualify. So again, this is not something that's super restrictive. Probably comes into play more when people who aren't as tall. It's probably more of an issue for women because women tend to keep their weight on their hips and their knees, whereas guys tend to keep their weight on their abdomens, which is actually worse from a medical standpoint, but from a knee standpoint is not as bad. Activity level. Again, you got to understand this is not, so you can go out and run a marathon. I don't like to do this in people, for instance, let's say you're a mason. Okay, you're going to be kneeling on your knee a lot. It's not the best thing to be doing on a knee replacement. So we have to take into consideration what people do, what they're going to be expected to do. But you can go back and do a lot of normal things. Again, a lot of this has to do with expectations. Next slide, please. It's done so, excuse me, the term we use is activities of daily living. This is so you can go to the mall with your kids, or go to church, or go play some frisbee or golf, or play a little one-on-one with your grandkids. This is not so you can beat your son in racquetball, or do that marathon that you always wanted to do. Running is something you can do, but shouldn't do, because it'll increase the risk of a complication and it's going to increase the wear of the implant. Next slide, please. Okay. So anytime you talk about something, you got to talk about the complications of that thing. So what are the risks of doing surgery or a total knee replacement? Well, anesthesia always has a risk. In a healthy person, the risk is minimal. Minimal isn't zero, but it's, minimal. And anytime someone's going to have these surgeries, we send them to their primaries to get checked out, so they can optimize your risk. So if your blood pressure is elevated, that needs to be controlled first. If you're diabetic, you'll need to have a hemoglobin A1C that's under 7.5. If you're a smoker, we're going to tell you should stop smoking. Some insurance companies will not do it if you're a smoker, again, because that increases the risk of wound healing. Some people's anesthetic risks are such that they are unacceptable risks for surgery. Other people, we say, well, you're at higher risk, but again, this is a judgment call. How big of a problem is this for you? How big is the risk? If this is keeping you at home and you can't do anything, you may be willing to take a somewhat higher risk than if it's just bothering you less often. Another risk is the risk of a blood clot, a DVT, or a PE, pulmonary embolism. The risk is fairly high if we don't treat this. So the standard of care is that for hip and knee replacements, we routinely prophylax with some type of treatment. Aspirin, warfarin, which is Coumadin, or some of the newer drugs. Most surgeons prefer aspirin. You take it for a month after the surgery. It doesn't lower the risk to zero, but it substantially lowers the risk. We don't do that in other cases. We don't do that in hand fractures or elective foot and ankle surgery because there isn't a big risk there. But in knee replacements and hip replacements, there is a big risk if you don't prophylax with aspirin or something else. We also encourage people to get up and move around quickly, which substantially lowers the risk of a DVT or blood clot. Infection. It's not that big of a risk statistically. Percentage-wise, you're looking at maybe 0.5%, but it's a big problem if you get one. If you end up getting an infection that isn't treated aggressively, it can result in the need to remove the implant, leave it out for a while, and put another implant in. So it's probably the biggest thing that we worry about practically. And again, the risks are very low. That's why we wear spacesuits in the OR. That's why we don't let any random people just stand around and watch. That's why we do a lot of things beforehand, including use antibiotics and things like that. So we take there's laminar flow ORs, so the air moves a certain way. So we take all kinds of precautions, and the infection rate is well under 1% for primary total knees, and for revisions, it's higher. It's 3 to 4%, depending on why you're doing the revision. Implant failure, much less of a problem than it used to be in the past, but still over time, the implants can loosen. A lot of that depends, some of that depends on technique, obviously. Some of it depends on the person, like if you're heavy, your implant's going to wear out quicker. If you're much more active, that's why we don't want you out there running on it. Stiffness. Sometimes you do the operation, x-ray looks great, you're thrilled to death, the patient's still stiff. The biggest reason why people get stiff beforehand is because they were stiff. Afterwards, because they were stiff beforehand. That has to do with the soft tissue around the knee. We can't completely control that, but it is a potential problem with the knee replacement. And then post-operative pain. Sometimes some people have pain because they have a problem, but there are other patients who everything looks great. You did the operation, you x-ray you're thrilled with, and their exam looks fine, there's no infection. And some people still have some residual pain. Next slide, please. It's not a big number, but if your patient is the one with that, it's obviously not something you like to see, and there are things that we can do to control that. But the success rate for no operation is 100%. Most of the studies show the success rate, satisfaction rates in the 90 to 95% range. Next slide, please. Okay, so this is a couple x-rays. Again, this is somebody that I did. So this shows an x-ray where you have some arthritis on the outside part of the knee. This is almost bone on the inside part of the knee. Next slide. The kneecap doesn't look bad. Next slide. And this is a post-op x-ray. This straightening out the knee. You can see it's symmetrical here. This is somebody who is 4 or 5 months out now, is out playing golf. Still a little bit stiff, but basically gets rid of most of the pain. And this is some situation. This is your standard. This is the standard knee that I do. This is a standard knee replacement. I'm going to compare it to something in a minute. Next slide. This is what it looks like from the side here. Next slide. So this is somebody who let the disease progress a little further. You can't necessarily appreciate on the x-ray, but this person has a fairly deformed knee. It's angled. This is one would have been easier to do 4 years ago than now, but some people put things off for any number of reasons. Next slide. Doesn't look as bad from the side. And then the next slide. So we were able to get this nice and straight, but it involves a little more soft tissue work. So I put this stem in there to give it a little bit more support. So, and again, next slide. And it's a picture from the side. Next slide. So really, I put that in there to raise the question, and I don't necessarily have the answer to this, is, when do you need to have a knee replacement done? I usually tell people, you don't need to have one. It's, people, you'll tell me when you need to have it. It's merely a function of how much it's bothering you, unless you start to get a severe deformity. You want to do it before the deformity gets severe enough where you're either too sick to do it, or where there's something that's occurring that's going to give you a less than optimal result. So what I generally do is, if I have somebody who isn't ready to have it done yet, I might say, well, even if you feel well, why don't you come back in a year and we'll check another x-ray. And then again, that's a judgment call, and you might get different things from different people. I have people come in to see me, they say they've been told by somebody, you need to have a knee replacement. I look at their x-rays and I say, well, you can have one, but if you're having pain every other Thursday when you do something for 10 minutes, probably don't want to do it yet. Other people, their deformity is such that, yeah, it's something you probably should do. So that's a discussion you need to have with your surgeon, is like, what's the difference between want to and need to? Again, realistic expectations are important. Riding a bike is something you can realistically expect to do after you have a knee replacement. Next slide. If this is what you're looking to do, you probably aren't going to be doing it anyway, but it's a knee replacement isn't the thing for you. Next slide. Again, golf, not a problem. I'd like to give people a free pickup out of the sand trap for the first 3 months after their surgery, so we don't want them climbing up and down hills. But basically, you can go back to playing golf. Some play doubles tennis. You don't need to be running around or twisting or turning the knee, but you can do normal activities of daily living. Next slide. That type of thing. Next slide. So again, I don't know if this actually makes sense, but some of the textbooks say you can play single tennis, doubles tennis, but not singles. What is meant by that is, you're not going to be able to cover the same area without running around as much. So you've got to have realistic expectations. If you've gotten to the point in life where you need a knee replacement, you need to decide, what's important to do and what's not. And, how can I preserve my function so I can do the things that I like to do without damaging myself? And again, tennis or racquetball is something you can play, but you're not going to be able to play it the way you did when you were 40 or 25. Next slide, please. Okay, so, and you can go to the closing slide, I guess. So again, because of the technical aspects of this, I'm not sure if I missed anything that I was going to be talking about, but I know there's a question and answer thing here. So if anybody has any questions about anything, I'd be more than happy to answer them. I guess Jen is now going to take over, assuming that you're on board with us here, and go from there.
Yeah, so if anyone had any questions that they put in at the beginning of the presentation, if you could just type those in again, simply because when I lost internet connectivity, I lost the questions as well. But I do remember a couple that I read, Dr. Nolan, so I'm just going to ask those to you offhand of the ones I remember I saw. One was that the person got on late, and she had a question about chondromalacia and what causes that, in case you did or didn't.
Sure. Well, chondromalacia is what we call idiopathic, means it just happens. We're not really sure why. It's softening of the cartilage under the kneecap. It's very common. I had it myself when I ran track in high school. Back then, they injected cortisone in kids more than they do now, so I got a couple shots. But it's self-limited, meaning it's generally it's a pain in the front of the knee. It can be excruciating. I can remember it felt like a knife going in my knee. but it was just when I was running, or people get it when they're going up and down stairs. And it's generally treated with physical therapy, some conditioning exercises. In an adult, maybe an injection and some anti-inflammatories.
Okay, great. And then another one I remember was, does exercise help or hinder arthritis?
Doing exercises the correct way helps immensely. Okay, I am a big fan of physical therapy. I do not think of physical therapy as some place you sign up for and spend the next 3 months of your life there. Okay, there may be some occasions when you have to do that for some things. I like to give people a script to go to see a physical therapist once or twice, learn how to do the exercises, make sure you're doing them correctly, and then do them on your own. And or if you belong to a gym or something like that, that is basically what I look at it. But yes, exercise is key. And if I don't send somebody for exercises before I do a surgery on them, it's because I forgot, because it's really almost mandatory that we do that.
Okay, and then I have another registrant who says no pain, but every now and then her knee feels like it's going to give out. It never does though. Do you have any recommendations?
Well, in general, I would say, and again, you can go online and look at some quick exercises and try that on your own, but you probably need someone to look at you, examine you, and start you on some conditioning exercises for a start. There's a couple of things that can cause that. It's likely not a ligament injury. It's possible a meniscal injury, but it's more likely irritation of the patellofemoral joint, something like the chondromalacia. And again, more likely than not, can be treated with some knee conditioning exercises. So if you haven't or can't figure out what exercises to do, that's a reason to come in and have me or somebody else that deals with knee pain take a look at you, check to make sure there's no mechanical structural problems, anything wrong with the x-ray, and give you some exercise to do. Would not necessarily right off the bat order an MRI for something like that. If you continue to have the problem and it was bothersome enough, that could be a sign of a meniscus tear, but I would start out with an exercise program first.
Okay, next question. I have some pulling feelings in my left knee when I sit down cross-legged. Is this a problem with my knee?
Well, hard to say. I'm not a big fan of sitting cross-legged for a number of reasons. Number one, and it depends on where the pulling is. So if it's in the back, it can be a hamstring issue. You could even have a small Baker cyst that's making it feel that way. Unfortunately, the devil's in the details. And so other than giving you some generic answers, which are most things you would start out by doing some stretching and some strengthening conditioning exercises. Beyond that, somebody would have to take a look at you and see exactly where the problem was, do an exam. Again, it could be a Baker cyst, which is a fluid-filled cyst in the back of the knee. It could be a hamstring issue. It sounds like it's not a surgical issue from what I'm gathering.
Okay, the next question. Can you have a total knee replacement if you have nickel/cobalt allergies?
Yes. And as it turns out, just coincidentally, the knee implant that you need is the one I happen to use all the time anyway. But what we generally do is get some testing done. And there is nickel in cobalt chrome, so you can use an implant that is titanium or has ceramic on the outside of it. We send people to somebody to do nickel skin testing, but yes, it is possible to do. Now, if somebody had an anaphylactic response to nickel, but almost no one does. Most people just have a sensitivity, and yes, there is an implant that you can do if somebody is nickel sensitive.
Great. Next question. Are there any exercises and/or machines that are contraindicated for arthritis of the knee?
I'm not a huge fan of stair climbers, and you don't want to do something where you're doing a lot of deep squatting or putting a lot of, so if you're going to do a leg press, I wouldn't bring your knee all the way in, the heel all the way up. But so that would be the main one.
Are knee issues or problems hereditary?
Not in a autosomal dominant thing where, well, my mother had it, so I'm absolutely going to get it, or the 25%, 50%. It is likely there is a genetic predisposition. Knee arthritis is what's called multifactorial, meaning it comes off multiple genes. Then you throw in your activity, you throw in what happened to you during the course of your life. So somebody might have good genes, but they weigh 300 pounds and they're going to get arthritis before somebody else who has bad genes but took good care of himself. But there's people that do everything right and end up with severe arthritis. They're 120 pounds. They never did anything. They're not runners, and they get severe arthritis. So there's clearly a genetic component to it. And I didn't mean to say, running is something that people like to do and they can do it, but a lot of repetitive impact loading can accelerate arthritis if you have it.
Okay, so those questions are answered in the Q&A. Let me just check the chat real quick. The chat is just a lot of compliments on a good presentation, so thanks for that. Is tachycardia side effect, is there, and I apologize for the pronunciation, tachycardia side effect with glucosamine chondroitin? Is there
Not that I'm aware of, but I'm guessing if you looked at the label, it's like the drug commercials you watch that they talk about the drug for 30 seconds and the complications for 10 minutes. It's possible any given individual might respond to one of the things in the product by being tachycardic, but in general, no.
okay? Bear with me on this one. Is osteoporosis on injection Prolia restriction or risk factor for a total knee replacement?
Having Prolia is relevant. That's a treatment for the osteoporosis, which is fine. Osteoporosis is not really a risk factor for a total joint replacement unless the person is severely osteoporotic, and then your surgeon may opt to use slightly different instrumentation in doing the surgery. For instance, I might put that stem that I showed that I put in that one person, I'd be more inclined to use a stem. I didn't talk about cement versus porous ingrowth, but some people use porous ingrowth where they don't use cement. It's the jury's not out on that, but you wouldn't do that in somebody's osteoporotic. So in general, you'd have to be pretty osteoporotic for it to be a problem.
Is Voltaren helpful?
Voltaren, either by mouth or gel, is helpful in arthritis. By mouth, it's an anti-inflammatory, so it has the same benefits and risks as the other anti-inflammatories, which is potentially kidneys. So people that have hypertension or kidney disease probably shouldn't take it. If you're on a blood thinner, you shouldn't take it. If you have a very sensitive stomach, people that are on that probably should have their BUN and creatinines checked every year or so. But no, it's an anti-inflammatory that can be helpful.
Does yoga help or give relief to knees?
Stretching can be helpful, yes. Yoga, I mean, it's a way of stretching. So again, the devil's in the details, but maintaining your flexibility is very, very important.
Okay, I think that is it on all the questions. If I missed any questions, I apologize. Please feel free to email me if you do have additional questions at programs@mbortho.com. I will then consult with Dr. Nolan and get back to you as quickly as I can. Again, thank you everyone for hanging in there with us today. I apologize. I lost internet connection in my office, which caused Dr. Nolan to.
And bicycling is a good exercise. Somebody just flashed that up. I don't know if I said that, but bicycling, keep your seat elevated a little bit, is a good exercise.
Great. So thank you, everyone. And if you would like to get an appointment with Dr. Nolan, please go to our website at www.mbortho.com. You can click on the appointment request button there, and one of our team schedulers will get in touch with you, or you can call our phone number 885-896-0444. Again, thank you for joining us today. Thank you, Dr. Nolan. It was a great presentation. We appreciate your time, and we look forward to seeing everyone next time. Thank you.